perfect.
Okay, perfect. Thank you so much. All right, good morning, everyone. I'm going to be speaking about advanced MR imaging for primary brain tumor diagnosis, focusing also on artifacts and pitfalls, which are very important. Don't have any relevant disclosures. And just to summarize from where we have been imaging and how what technologies we have been using in the past couple of decades, since the early 80s, there has been a search for imaging techniques that could provide a definitive diagnosis of brain masses, and CT was the first imaging modality that was used. And CT can very well show us findings such as calcification, the density of the mass, contrast enhancement. But the problem is that it lacks sensitivity and specificity. And so with the advent of MR, most of the brain imaging work is being done with MR after initial diagnosis by CT, usually in the emergency setting. And then MR, either conventional sequences and subsequently advanced MR imaging has been used for characterization of brain tumors. And so there are a lot of things that can be achieved with MR. We can use contrast enhancement to look at the vessel integrity and blood-brain barrier disruption. We can use DRE or SWI sequences to look at hemorrhage. We can use diffusion-weighted imaging to look at tumor cellularity. We can use perfusion imaging to look at the tumor angiogenesis. And we can use MRI spectroscopy to look at tumor metabolism. And also we can use MR, fMRI, or magnetoencephalography to map the tumors before surgical resection, whether that's a cortical mapping with functional MRI. And we can use DTI for subcortical mapping and to evaluate the relationship of the brain masses with different tracts by tractography. So there has been many efforts to basically characterize brain masses using MR, using advanced MR. And this is not a new algorithm. It actually was published almost 2 decades ago by our group at Penn, and basically using different thresholds on MR spectroscopy, diffusion and perfusion, and in a group of patients with interactable brain masses, and using it to differentiate between different histologies and tumor and non-tumoral etiologies. And so I'm going to go over these techniques and outline some of the indications and also look at some of the pitfalls. Starting with MR spectroscopy. When we do MR spectroscopy in a mass, especially in this patient with high-grade glioma, this is the typical MRS that we see. We see marked elevation of choline compared to creatine and significant elevation of NAA. Compared to MRS in a normal aspect of the brain, which shows decreased levels of choline compared to creatine, no elevation, and preserved level of NAA. So there is a very striking difference between MR spectroscopy in a high-grade tumor compared to normal brain parenchyma. And we can also use MRS to differentiate high-grade glioma from metastasis, because high-grade gliomas tend to be invasive into adjacent white matter. And so in this patient, you can see that the MRS that's located in the voxel from a multi-voxel MR spectroscopy is located over the enhancing component of the tumor, and shows marked elevation of choline to creatine, decreased NAA, and the voxel that's located in the white matter surrounding the tumor still shows elevation of choline to creatine, indicates that the tumor goes beyond the enhancing component, and this is an indication that we're dealing with a high-grade glioma rather than a brain metastasis. This is a patient with a brain metastasis, and you can see that the voxel that is inside the enhancing component shows elevation of choline to creatine, but the voxel that is in the white matter shows absence of choline to creatine elevation, indicating that this is a brain metastasis. And what we see in terms of surrounding T2 prolongation is vasogenic edema and not infiltrative tumor. One pitfall to be aware of when dealing with MR spectroscopy is that some of the low-grade tumors could have relatively normal MRS. The NAA is decreased in this case, but you can see that the choline to creatine is not elevated. This was a grade 2 oligo. Another patient with a grade 3 astrocytoma, again, you can see that the choline to creatine is not elevated. NAA is decreased, and there's also some elevation of lipid lactate. But again, one emphasize that elevation of choline to creatine does not necessarily happen in all of the patients with brain tumors. This is a patient with a cerebellar dysplastic gangliocytoma or Lermite-Duclos, and again, the MRS does not show elevation of choline to creatine. This is a study that we did about almost many years ago, but showed that about 15% of grade 1 to 3 gliomas show lack of elevation of choline to creatine ratio compared to normal brain parenchyma. So the pitfall is that if there is lack of elevation of choline to creatine, it cannot exclude a brain tumor, especially when you're dealing with the lower grade gliomas. Another pitfall is that we have to be aware that elevation of choline to creatine is not specific to neoplasms. We can see that this patient with tumefactive demyelination can see this preventricular lesion with some enhancement, and there's marked elevation of choline to creatine, some decreased NAA, prominent lipid lactate peaks, and this was not a tumor. And another patient, this patient has 2 lesions, and you can see that they're hypodense on CT. There's some restricted diffusion peripherally on MR. And again, this is something that could basically, patient can come to the ED and then subsequently have MR after CT. And then the question would be, is this a tumor or not? MR spectroscopy showed marked elevation of choline to creatine. And but that was, again, tumefactive demyelination, not tumor. So shifting gears to perfusion MR. By doing perfusion MR, we can measure the rate of blood flow through capillary circulation of an organ or tissue. And it commonly normalized to the bulk of the blood flow rate divided by the organ mass per 100 gram of tissue. And so comparing the brain, cerebral gray matter, as expected, has a higher perfusion compared to white matter, usually 60 ml per minute per 100 gram of tissue compared to 20 in the white matter. And that's actually much lower compared to what we see in the myocardium, which is usually in the range of 100 during rest to 400 during maximal exercise. And so looking at a simple model of blood circulation, we have an arterial input and a venous output. So the blood flow basically flows through the tissue, and then the blood volume is the volume of the blood that is present at the tissue level, and we report it per ml per 100 gram of tissue. And so using MR, there are a couple of ways to use perfusion techniques to image perfusion. We can use it with using contrast agents and use either T2-based dynamic susceptibility-weighted MR or DSC MR, or T1-weighted dynamic contrast enhanced MR or DCMR. Or we can use endogenous tracers, which is water, which is a freely diffusible tracer, as an endogenous tracer. So we can do perfusion without using contrast agents. In this talk, I'm going to focus on the perfusion techniques, DSC and DCA. Starting with DSC, we basically infuse a bolus of gadolinium intravenously, followed by a series, usually somewhere between 60 to 120 series of echoplanar imaging. And because gadolinium is injected at a very high rate with a large gauge venous catheter, we have high concentration of gadolinium in the vessels. And because it's confined to intravascular space, it basically causes loss of signal because it's called dephasing and magnetic inhomogeneity and signal drop. And then by measuring the signal intensity as a function of time and fitting it into a mathematical model, we can measure various perfusion parameters of blood flow, blood volume, mean transit time. So here's how it works, as I mentioned, because of the first pass. So because this echo planar, so very rapid imaging. And so during that time of rapid imaging, gadolinium will be limited to the intravascular space and have high concentrations. And that's why we have signal drop. And that's the T2 star-weighted imaging. And so sometimes when you do body imaging and when you look at the gadolinium, the dependent gadolinium in the bladder, you can see that it's dark. And you can also test it on the magnet. If you pour gadolinium in a cup and measure and basically image it, it will be completely dark because of high concentration of gadolinium basically causes signal drop. And so here is how basically images look like. You have baseline images, when contrast passes through the tissue. You can see signal drop in the vessels, in the cortical vessels, and also choroid plexus. And then subsequently, we have a return to the baseline. And this is a patient with glioblastoma in the genie of corpus callosum. So by looking at the contrast-enhanced MR, we can certainly basically indicate that this patient has disruption of blood-brain barrier. But that's as far as we can tell. If you want to quantify the tumor neoangiogenesis and tumor vascularity and the degree of blood-brain barrier disruption, we have to do some sorts of perfusion imaging. So in this case, we did DSC perfusion, and you can see that this is the baseline that we do echoplanar imaging. And then at this point, there is a signal drop because contrast enters the tissue, the brain, and tumor, of course, and then we have signal drop. Then subsequently, we continue to image, so we can see that there is a return to the baseline. And so by measuring this signal drop, we can do multiple things. Again, showing what happens, and you can see that baseline, return to the baseline, but during contrast passage through the brain and tumor, you can see signal drop through the normal vessels and also tumor vessels. And by quantifying that, we can measure perfusion. And here's how we do it. We can measure the arrival time to the tumor. We can measure the area under the curve, time to peak, and person signal recovery. So there are different ways that we can do it. And this is semi-quantitative measure. If we do mathematical modeling, we can actually measure the cerebral blood volume, cerebral blood flow, and mean transit time. And here is the final maps of this patient showing increased perfusion, which is quantifiable, and we can normalize it to the normal white matter. And these are color maps overlaid on FLAIR and T1 weighted imaging. So perfusion imaging, DSC, is very helpful with one pitfall, which is the blood products degrade perfusion because these are echoplanar T2 star weighted images. So if there is hemorrhage in the tumor, or more commonly, these patients undergo surgery. So there are usually post-surgical changes from surgery causing susceptibility artifact, chronic blood product, surgical material. And so here's a patient and with GBM, and you can see that there is a contrast enhancement. However, when you look at the source perfusion images, you can see there's a lot of susceptibility, and we can see, sorry about that, we can see the artifact on perfusion maps. And so that's why sometimes if there is a lot of susceptibility, we need to use the other perfusion technique that I mentioned, which is dynamic contrast enhanced perfusion MR. So this is a T1-based technique. So unlike DSC, we use repeated T1-weighted imaging, usually a 3D spoiled gradient echo technique over approximately 5-minute interval. And during this time frame, gadolinium contrast accumulate within the tissue extracellular space at a rate that's determined by perfusion and cerebral blood flow and capillary permeability and surface area of the vessels. And so I'm actually going to play one of the acquisition for you. And you can see at the beginning, there is no contrast. We just keep imaging. So some brightness that you see is in the vessels is due to a slice entry phenomenon, or kind of like a time of flight phenomenon, because of the protons are fresh and are not suppressed, but there is no contrast in the brain yet. So I'm going to move forward, and you can see that the contrast after about like 40 seconds, the contrast enters the brain. So at the beginning, the contrast is going to be in the big vessels. And then, but eventually it's going to basically diffuse into the tissue, and you can see more and more enhancement of the tumor as we move forward in image acquisition. So obviously the tumor is in the right parietal region. And then we keep imaging for a few minutes. This was a shorter acquisition, but acquisition is about 5 minutes. And so we can do a full quantitative analysis of DCE data by conversion of signal intensity to gadolinium concentration. And we have to select an appropriate tissue model. And then we can estimate the model parameters from the fitted data. The model that we usually use is a modified Taft model that gives us the K-trans, which is a transfer contrast between blood plasma and extravascular, extracellular space or interstitial space. So this is K-trans. VP is the plasma volume. In the context of tumor, the higher the VP, the higher the chance of this would be a high-grade tumor or progression compared to pseudoprogression, because VP, you can think of it as tumor vasculature. And then we have VE, which is extracellular, extravascular fraction or interstitial space between the tumor cells or whatever cells are in the tumor microenvironment. And finally, you have KEP, which is the transfer contrast between the interstitial space and basically plasma. Here is a patient with a post-treatment GBM patient. You can see T2, flare post-contrast T1, and you can see the different maps, K-trans, VE, and VP. All of them are elevated, but I mean, you can look at them visually, but most importantly, we can quantify them, we can normalize them to the white matter, and we can use the absolute values. And this is very helpful when we're dealing with susceptibility, and we can use DSC imaging. Again, the patient that I showed you before, that the DSC imaging shows a lot of artifact. Here, we used the DC imaging successfully. There is no artifact, and we could basically see that how much a VP is elevated, and this is consistent with the tumor progression. So in this case, DSC was not helpful, non-diagnostic, but DC helped us to basically tell the clinicians that this is a tumor progression. So I'm going to go over quickly indications for tumor, different indications of using perfusion imaging for in brain tumors. One is tumor grading, and higher grade tumors, like you can see here, GBM and metastasis, they usually have much higher perfusion compared to lower grade gliomas, as you can see in the bottom row. One pitfall to be aware is that some of the low-grade gliomas can demonstrate elevated perfusion. You can see this left frontal tumor with some enhancement and significant elevation of perfusion. This turned out to be an oligodendroglioma. And this patient also shows marked elevation of choline to creatine. One important indication for using perfusion is distinguishing neoplastic versus non-neoplastic etiologies in brain masses. And this is a patient, 42-year-old with MS. that during the routine MS follow-up came with this MR that showed a large parietal lesion after a fall, and the patient was imaged. You can see rim enhancement, but incomplete rim enhancement with the lack of enhancement facing the cortex. The perfusion is mildly elevated, and so this can tell us that this is not a tumor, because in tumor enhancing tumors like this, we expect perfusion to be elevated more than this. And also the conventional MR pattern helps us, the history helps us, but perfusion is a problem solver in this case. And this patient was followed after initial imaging without any intervention, and you can see that this lesion decreased in size, and after 8 months almost was like the other lesions that the patient had. So this is how perfusion could help us. And this another case, actually, this patient did not have a history of MS, had some neurologic problems, and neurosurgeons actually sent this patient for preoperative mapping. They ordered MR and perfusion, and also they ordered DTI, and this is the DTI, so you can see that there's this mass-like lesion, and we can see the fiber tracts like this, the arcuate fasciculus, and how close this is. But then when we looked at the perfusion, we saw that there is very mild elevation of perfusion. We thought that this is could be a demyelinating lesion rather than a brain tumor. And so we advised the neurosurgeons to follow this patient rather than doing surgery. And this is the follow-up imaging. You can see this is the baseline, 1 month follow-up, 2 month and 4 month follow-up. Lesion decreased in size without the need to do surgery. So sometimes perfusion could be really helpful in preventing an unnecessary surgery for patients when they don't need that. Perfusion can also be helpful when lesions look like demyelination, but you're not, like this lesion who has this finger-like periventricular lesion, which could look like a tumefactive demyelinating lesion. With some enhancement, perfusion shows marked elevation. This turned out to be a glioblastoma. Some of the pitfalls to be aware of: sometimes infection could show increased perfusion, especially infections that are chronic, mainly in the context of fungal infections. Patient right frontal mass, 42-year-old with seizure. You can see this mass-like lesion with some enhancement. Perfusion showed moderate elevation. Cold creatinine was elevated. This patient underwent sampling of this, and this turned out to be a fungal abscess. This is a pyogenic abscess that you can see ring-enhancing lesion in left frontal lobe with restricted diffusion and actual elevation of perfusion. And this patient had pyogenic infection with elevated perfusion, kind of unusual setting and appearance. We don't usually expect pyogenic infections to show increased perfusion, but occasionally they do. And so something to be aware of. The cold intracranial was also elevated. This is a study that we published looking at the brain infections versus necrotic glioblastoma, and we showed that the CBV max from DSC perfusion is significantly higher in GBM compared to infection. But again, as I showed, there are cases that infection could show elevation of perfusion, as you can see some of the higher range of perfusion in infection. So one thing that I want to emphasize is that sometimes benign vascular anomalies in brain show up on perfusion imaging as high perfusion. The most common benign vascular anomaly in the brain is DVA, which is a network of vessels that look like a caput medusa and basically center around a drain through a central vein. And because of the alteration of hemodynamics, they can show increased perfusion. And also developmental venous anomalies can show metabolic abnormalities on FDG PET imaging. So this is a DVA. You can see the caput medusa appearance, central vein. And when we look at the perfusion imaging, you can see that these are CBV maps. You can see elevated perfusion in the territory of this large developmental venous anomaly in right cerebellum. You can also see a cavernoma associated with it. And so something to be aware of, especially because DVAs are common, and you can occasionally see a DVA adjacent to a tumor. And so it's important to be aware that if we see increased perfusion, is it because of the tumor or because of the DVA? Capillary telangiectasias can also show increased perfusion. Usually you don't see any hypermuscular flare. You see faint enhancement on MR and show susceptibility and increased perfusion on RCBV maps. So again, capillary telangiectasias are common, so something to be aware of. And as I mentioned, DVAs can also show metabolic abnormalities on FDG PET, about 38%, which is actually a very high number. And so you can see this DVA showed decreased metabolism in the territory of DVA in left cerebellum. This one actually showed decreased uptake in left anterior temporal lobe, and the patient actually underwent anterior temporal lobectomy because of decreased activity, which in retrospect was attributed to the DVA and not an epileptogenic focus. So this is a very important pitfall. Finally, I'm going to focus on indication of MR perfusion imaging for evaluating response to therapy, and also the distinction of progression from pseudoprogression. Radiation necrosis is something that usually happens 6 months or more after treatment. And so in those cases, perfusion is very helpful. Like you see here in the baseline imaging, there is some enhancement with significant increase on follow-up imaging after 12 months, but perfusion imaging almost does not show any increased perfusion. And this patient underwent resection, and it turned out to be, we're dealing mainly with treatment effect and not basically progressive neoplasm. And so if you look at the cases of pseudoprogression, mixed and true progression, you can see that perfusion, the contrast enhanced T1 could be very similar. So it's really difficult to distinguish these using contrast enhanced MR. However, you can see that the RCBV is significantly elevated on true progression compared to mixed and mild, to mixed and pseudoprogression. And mixed usually is the in between. Basically, if we give a percentage to pseudoprogression, which is like usually less than 10%, and true progression, if we call it more than 50%, mixed is usually somewhere in between. And so this is a study actually from Penn a few years ago, published and looked at the various thresholds of different MR parameters, and they showed that RCBV max could have an AUC of about 0.77, sensitivity of 0.62, and a specificity of 0.8, 80% to distinguish true progression from pseudoprogression. So basically, perfusion could help us, even though it's not perfect. It has false positive and false negatives. But in the MR techniques, MR perfusion with CBV could help us to distinguish between progression from pseudoprogression. This talk is about MR, but there are techniques that are superior to MR, including amino acid PET, that has been shown to be superior to perfusion MR in distinguishing between progression and pseudoprogression. But this is a separate subject, not within the scope of this talk. And so one of the basically treatments that has been more and more used in the context of gliomas are immunotherapies and vaccines. And these treatments could be associated with pseudoprogression and increased perfusion, despite most of the pathology showing necrosis. And you can see two examples here that this patient after 6 months showed 80% necrosis on histology. However, you can see that the perfusion is elevated. Another patient after 12 months, 60 to 70% necrosis, significant elevation of perfusion. So these are kind of things to be aware of, that it's not black and white. Usually we're dealing with a combination of necrosis and tumor, and usually in patients who have underwent immunotherapy, this window could be lengthened in terms of seeing the pseudoprogression and increasing enhancement following treatment. So finally, in the last few slides, I'm going to talk about tractography. And as you might know, there are a couple of ways of doing tractography. The most common way of doing it in the clinic is deterministic tractography, that we have the region of interest selection and using a post-processing software, and then we can connect these region of interest by looking at the fractional anisotropy basically of each voxel, and basically connecting them by following the highest FAs between two ROIs. So you can see here, this is arcuate / superior longitudinal fasciculus. This is corticospinal tract. So this is the deterministic tractography that we use in the clinic commonly. One of the limitations of deterministic tractography is that differences in ROI selection may produce different appearances of tracts, as you can see here. And that's why automated whole brain tractography somehow is solving this limitation by basically automatically generating these tracts. So basically decreasing the operator variability by basically omitting the manual ROI placement. So this is one kind of new version of processing tractography I wanted to mention, and you can see a reference from my colleagues here that you can refer to for more information. And one of the pitfalls of doing tractography is that high-grade gliomas and also brain metastases, they usually have peritumoral edema and increased free water, which reduces the ability of standard DTI software to perform tracking. And the fiber tracking may abruptly terminate in the areas of increased edema. As you can see here, there is a tumor here, but you don't see much detail. It's almost like everything stops at the time reaching this area. And so to address that, actually, to address the problem of pre-lesional edema, and you can see that when there is edema, the FA values decrease significantly, as you can see in this color map. A group of investigators at Penn, led by Dr. Ragini Verma, developed this technique called FERNET, which corrects for edema to overcome the limitation of multi-compartment modeling of diffusion data. So basically, in the peritumoral voxels, they basically can separate the component of free water, isotropic component, from the anisotropic nerve axon fibers. And the FERNET, which is basically the new version that basically take into account free water, can show the fibers in more detail compared to the standard tractography. As you can see, these fibers are kind of additionally shown in more detail. So you can see this patient with a left parietal suspected glioblastoma, and basically this is the standard tractography. You can see that because of the marked edema surrounding the tumor, which is shown in purple, and the edema in green, you can see that the fibers kind of stop when they reach the tumor area and the edema. But by doing the FERNET, you can see that we can see many new fibers surrounding the tumor. So this technique would allow us to see the invisible fibers on a standard acquired DTI software. And so that can be very helpful, and this is an area of active research at Penn. So in conclusion, conventional imaging is helpful, but is limited in characterizing brain masses. And so we need to take advantage of advanced imaging with multiparametric imaging to identify radiophenotypes and also in post-treatment evaluation of brain tumors. And it's important to be aware of the pitfalls and limitations of advanced imaging to avoid a diagnostic confusion. And thank you very much. I'll be happy to take any questions.